So let me introduce myself and continue. The next talk is by as we'll discuss about the dose of renal replacement CRRT. Yeah, and so as now till now we have understood that we have a machine which basically filters blood, takes out toxic substances from the blood, make the blood more, in fact, if it is more acidotic, it reduces the acidosis. It takes out the excess of fluids, that is, fluid overload is controlled with the help of ultrafiltration, as Dr. Vivek was saying, that when you are doing convection, that is, you are removing the molecules against pressure gradient. We are giving a lot of pressure in the blood, and that by pressure gradient, the pressure in the dialysis is less. So the extra amount of not only the solutes, along with the solutes, a lot of water is also being taken away. So the patient, from the patient, we are taking a lot of fluid out, and we are substituting with some amount of fluids to the patient. And as Dr. Vivek was correctly saying, this is not replacement therapy, but the replacement solution is basically a substitute to what you are taking out from the patients. And if you are taking something over and above what you are taking, the fluid that you are taking out, that is the extra patient fluid removal that you are doing in cases of volume overload. So when you select a patient, you select according to exactly what do you need in the patient. For example, you need to clear the acidosis. So you can just go in for a CVVD, where or you have to remove the middle molecules for sepsis. You can go for CVV where you're not only doing a dialysis but also with ultrafiltration. You have to remove more of volume. Suppose in case of pulmonary edema, you can go for CVVH or slow continuous ultrafiltration. You can only just take out some amount of fluid from the patient, that is known as slow continuous ultrafiltration. As we can see in this patient, this is a patient who came post-delivery in severe AKI, ARDS, pulmonary edema, multi-organ failure in 2011 in our ICU. So as you can see that the patient came with ARDS, AKI, pulmonary edema was there, the patient was in volume overload, the patient was in severe sepsis, multi-organ failure, and the renal support was given in the help with the help of this Prisma machine. It's an old machine. You don't find it nowadays in the modern medical practice, because it's taken out of the market, and they saved many patients. If you have seen properly, you have seen that all the 4 pumps are working. That means we are doing a CVV HDF here. So that the effluent pump, the blood pump, every pump is working, as Dr. Vivek showed you the different pumps. So what basically, when we calculate the dose of intermittent hemodialysis, we all know that we measure the KT by V urea. That is the efficacy by which the urea is removed from blood. So K is the efficiency, that is the volume of blood cleared of a given solute over a given period of time. K into T is the intensity, and K into T by divided by V is the volume of distribution of that particle solute, as urea is equally distributed all over the body water. So urea is considered to be the molecule. Here and the surrogate molecule to show the effective the effective clearance by the dialysis, and we take out the fractional excretion of the given solute, that is Kt by V. I give you an example. For example, 70 kg man treated with 20 hours a day with a post-filter hemofiltration of 2.8 liters per hour. So K, that is efficiency, is what? 2.8 liters per hour. That is 2800 ml. 2.8 liters is 2800 ml over 60 minutes. So per minute is 2800 divided by 60, that is 47 ml per minute. Now it is done for 20 hours. So 20 hours means 60 into 20, that is 1200 minutes. So the intensity is 47 ml per minute into 1200 minutes. That comes, that is the intensity. Now, what is the volume of distribution of urea? That is, in a man, it is 60% of the, is 70 kg, so 60% is the volume of water, that is equal to the volume of distribution of urea. So that is 60% of 70 kgs, that comes around 42 liters, that is 42,000 ml. So what is the efficacy? Kt is 47 into 1200 divided by 42,000, that is 1.3. So we basically target this value of 1.3, or if we do 3 times a week, it comes around 3.9. That is basically the target that we try to achieve in hemodialysis. But what is the problem in patients of acute kidney injury, in patients of sepsis, in patients who are critically ill in your eyes? These patients are not stable because we are not sure about the volume of distribution. Either they're hugely volume overloaded, or they're having unstable volume, and their metabolic state is completely unstable. And as I told you, they have a labile full fluid volume, and the patient might have a residual renal function which changes dynamically during the course of treatment. It is not a sick anemia. Sometimes the patients of AKI many times have, and most of the times they have a good kidney. Suddenly they go into failure due to all the insults that the kidney faces. And that leads to this problem. So the residual renal function is still there. So we just can't predict that what state the patient is in. And you are in a lot of vasopressors. You have a solid disequilibrium within the tissues and organs. And you have technical problems of ISD, definitely in these type of patients. So that is the reason why this formula Kt by V does not stand in the practice of CRRT. So that is the reason the first failure of ISD is its dose, which cannot be validated in patients of acute kidney injury. So what is the dose here is calculated? It is the effluent rate. What is the effluent rate? Effluent rate is equal to the dialysate fluid that we are giving, and the ultrafiltrate, by the pressure, the amount of fluid that I am taking out. These two fluids are accumulating in an effluent bag, and that the rate at which that bag is being filled up is known as the effluent rate. It is basically the surrogate of removal of solutes inside the in the patient. And as we have seen that there are certain, Dr. Vivek has said very clearly, there are certain small molecules which freely travels across the membrane, like urea, like creatinine. So their concentration in the blood is equal to the concentration in the dialysate, and which that is the effluent. So this is known as the sieving coefficient, and that is the reason why effluent is considered to be a surrogate marker of removal of the solids. So total dose is effluent rate. Suppose you have a dialysate rate and an ultrafiltrate rate. So ultrafiltrate is the amount of fluid you want to remove from the patient. And that is basically the replacement fluid that you are giving also to the patient. So dialysate rate plus replacement fluid rate. For example, dialysate rate is 1000 ml per hour you have set in the machine. And the ultrafiltrate rate you have set 1000 ml per hour. It is written replacement fluid there in the machine. So the effluent rate is 1000 ml per hour plus 1000, that is 2000 ml per hour. So in a 50 kg individual, it is 2000 ml divided by 50, that is 40 ml per kg per hour. So here, dialysate rate plus ultrafiltrate rate is equal to the effluent rate. It is zero balanced. Why? Whatever you are taking out, you are giving back to the patient. So now if we add on to this the extra patient fluid removal, suppose you want to add 100 ml of fluid per hour from the patient extra, and you don't want to because the patient is voluble already. So 100 ml per hour extra means in 24 hours you're taking out around 2.5 liters for the patient. If you want to do that, for example. So that fluid, then the effluent rate, what does it become? It becomes 1000 plus 1000 plus 100 ml per, that you are taking out extra. So this 2100 ml. So it becomes 42 ml per kg per hour. See, it is more than the dialysis rate plus the ultrafiltrate rate because patient fluid removal has been added to this. So this is known as a negative balance CRRT. So either it could have a zero balance CRRT or a negative balance CRRT. And let us, this is in CVVHDF, that is continuous veno-venous hemodiafiltration. And here you are doing both dialysis and ultrafiltration. Now, if we don't do dialysis, if we don't do ultrafiltration, only we take out patient fluid removal, 100 ml per hour. That is SCUF, slow continuous ultrafiltration. So dialysis 0, ultrafiltrate 0. You just put patient fluid removal 100 ml per hour. That becomes slow continuous ultrafiltration. Excellent in patients of heart failure, especially pulmonary edema. PIH, in patients of PIH, the patient coming with pulmonary edema. Just think the patient's blood pressure is 60. Systolic blood pressure is 60. You have a lung full of water. How you are going to remove it? You first of all add vasopressors. You just pray, let the blood pressure come up. Then you can add a bit of diuretic. So that becomes a very cumbersome approach. One of the approach was used by Coderman. It is in 2012. It was known as a PAL approach. He intubated the patients. Used to give a PEEP. Used to give albumin to make the blood hyperoncotic, and used to give Lasix. So this type of jumbled up approaches are used. But if you can use a bit of SCUF where you can slowly take out this fluid, you can go from 100 to 400 also per hour. So that extra amount of fluid that is there in the lung can easily be removed, and their SCUF is useful. Whereas the above CVV HDF, your patients of sepsis, where you not only have to remove the acidosis, but also you have to take the extra volume of water from the patient. You have to remove those middle molecules, TNF alpha. You don't know, it might be helpful. And there you will start with the CVV HDF. Remember, when you're in the initial stages, when your blood pressure is low, if you're suddenly giving a CVV HDF, your blood pressure might fall a bit more. So start maybe with the dialytic process, slowly move to the ultrafiltrate process, or vice versa, so that you make it more smooth. So now we go to CVV HD. Suppose you are doing continuous veno-venous hemodialysis. Here the dialysis rate is 1000 ml per hour, but the ultrafiltrate is 0. You don't want to take any amount of extra fluid from the patient. For example, you just want to remove urea, creatinine. You want to just remove, improve the acidosis part of the patient. So there you do a dialysis. So here the dose becomes in a 50 kg individual. So in the effluent, only 1000 ml is coming. In a 50 kg individual, it becomes 1000 divided by 50. That is 20 ml per kg per hour. Now, just the opposite, you are doing only hemofiltration. You don't want to do dialysis. You want to take out the volume only. So what you are doing, you are doing an ultrafiltration of 1000 ml per hour. So effluent rate becomes 1000 divided the same. It becomes 20 ml per kg per hour. But here you are doing only ultrafiltration, not dialysis. So, but as I have told you, when you're doing ultrafiltration, you're replacing the fluid either before the blood enters the filter, that is pre-dilution or pre-filter, or after the blood comes out of the filter, that is post-dilution. Dr. Vives has already told you what are the advantages. But think, when you are giving this fluid pre-dilution, you are diluting the blood. So whenever you are diluting the blood, your equation, your dose changes a bit. How? I will show you. Now suppose Kp is the prescribed dose that you have given, that is the prescribed dose that you want to give. And here you have the effluent rate, or the QE is the prescribed effluent rate. Suppose you have prescribed something. I want to do this. And the blood water, this multiplied by the blood water, the plasma flow rate, divided by the blood water and the replacement fluid that you are giving, that is QRF, is the replacement fluid that you are giving pre-filter, because you are diluting the blood. So your dose will become a bit less. And how do you monitor that? How do you monitor that? You monitor your solute clearance, that is the total effluent volume, TEV, multiplied by, you have to measure the effluent urea nitrogen, and you also have the blood urea nitrogen. This is basically 1. If the sieving coefficient is 1, because the concentration is same in both the sides, it is 1. But if this goes on decreasing, that means your filter is started clotting or clogging. So there the solute clearance will decrease. So if you measure them regularly, you will find when your solute clearance is decreasing, that means your quality of dialysis or hemofiltration is coming down. So either the creatinine or the urea or both you can measure in the effluent bag by taking the fluid from there, and in the blood. Take the ratio. If it is 1, it's fine. If it is coming down, that means your quality of dialysis is coming. I'll give some examples. Filtration fraction has been explained by Dr. Vivek. I'm not going into the details of this. Sieving coefficient has been told by him. Now let us see this illustration. Suppose you are replacing that pre-filter before the blood is coming inside the filter by 300, and your dialysate rate is 1000 ml per hour, you have said. And you are removing an extra fluid of around 700 ml from the patient. That is the patient fluid removal, which you are also replacing to the patient, is about 700 ml. So what is your effluent rate? 300 ml that you have given, plus 1000 ml of dialysate, plus 700 ml that you are removing. So total 2000 ml per hour. That is 40 ml per kg per hour in a 50 kg individual. This is basically the dose. Now what is the blood flow here? Now blood flow, suppose you have set 100 ml per minute. So that is 600 ml per hour, 6000 ml per hour, 100 into 60. So what is the plasma water flow? Plasma water flow, the blood water, that is 1 minus hematocrit into blood flow. So the plasma flow is 1 minus hematocrit into heart flow. For example, hematocrit is 0.3. So what is your blood water, the plasma water flow? That is 1 minus 0.3 into 6000. So it's 0.7 into 6000, and 4200 ml per hour. So this is your plasma flow that is getting filtered inside. So now see how the calculation changes. So what is your prescribed clearance? Your total effluent you have seen, it is 2000 ml multiplied by that is the blood water flow, that is 4200 that you have calculated, divided by 4200 plus you have diluted it with 300 ml of pre-filter. So it becomes 4200 plus 300. That is 4500. And divided by the weight of the patient, that is 50. So you started at 40 ml per kg per hour. Due to pre-filter addition of 300 ml, the calculation becomes 37 ml per kg per hour. And this is your prescribed effluent, 2000 ml. Many a times you have stopped, the machine has stopped to change the bag. There are some nursing stations, there are some complications. So ultimately you found that in 24 hours, it was not 2000 ml, it was 1600 ml. So your clearance becomes 1600 ml into 4200 divided by 4500 divided by total divided by 50, that is per kg per hour. So it becomes 29 ml per kg per hour. So you started at 40 ml per kg per hour. Due to pre-filter, you decreased at 37 ml per kg per hour. Due to stoppage time, you decreased to 29 ml per kg per hour. This is the beauty that you have to understand here about the dose. So whatever you prescribe more, you basically achieve less. And if you are giving a pre-dilution, so obviously the quality is coming down and your effluent dose is also coming down. And how much blood you are going to give? What is the blood that you are going to send? Blood flow. So if you are doing CVVHD, continuous hemodialysis, it should be at least 2.5 times your dialysate rate. 2.5 times. For example, if you are having a dialysate rate of 2000 ml per hour, that is 2000 divided by 60, that is 33 ml per minute. So your blood flow in ml per minute will be 33 into 2.5. that is at least 83 ml per minute or above. If you give it below that, it will not work properly. Suppose you are going to do a post-filter continuous hemofiltration. Post-filter means you are replacing the fluid when the blood is coming out of the fluid. Post-filter. So it will be at least 5 times the hemofiltration rate. For example, you have set a hemofiltration of 2000 ml per hour. So that is 33 ml per minute. So 33 into 5, that is 165 ml per minute, should be the minimal blood flow that you have to set when you are doing a hemofiltration with this rate. If you are setting 100, it will not be successful. Now, if you are doing a pre-filter hemofiltration, that is, you are adding some amount of fluid before it is entering the filter. So there it should be 6 times your hemofiltration rate. For example, in a pre-filter hemodiafiltration, your pre-filter fluid is around 1000 ml per hour. That is 17 ml per minute. So 17 into 6 times is 100 ml. So at least 100 ml you have to give in a pre-filter hemodiafiltration. That is, if you are giving pre-filter. And suppose you are giving a dialysis sort of 1500 ml per hour, that comes around 25 ml per minute. For hemodialysis, you have to be 2.5 times. So 25 into 2.5 is 63. So you should not consider the smaller one. You should consider the larger value. So at least this is the way how you calculate how much amount of blood flow you have to set in the machine. So now you know how much amount of blood flow you have to set in the machine. You also know how to set the dialysate rate, how to set the ultrafiltrate rate. If you are giving something pre-dilution, remember that the effluent rate, your values will be coming down. So now you know that. Now the most important part. Whatever fluid you are taking out from the patient, you are replacing it. Now you want to remove over and above some amount of fluid from the patient to decrease this volume overload the patient is having. So suppose you want to remove 100 ml per hour. So the net fluid removal hourly, that is your order, is 100 ml per hour, plus the non-CRRT intake. Suppose you must be giving IV fluid to the patient. You must be giving total parenteral nutrition to the patient. You have to add these two, minus the patient's urine output, if there is at all some urine output. That is the removal rate you have to set in the machine. I will give you an example. Suppose 50-year-old male is going on CVV HDF day 3. Intensivist wants to remove 100 ml per hour. And in the last hour, you see the patient received 200 ml of tube feed nutrition. He has also received IV vancomycin 100 ml per hour. So totally, he has received 200 plus 300 ml per hour. He has received. And his drain was 50 ml and urine output was 120 ml. So in that hour, he has taken out how much? 50 plus 120, that is 170 ml. So you want to remove how much? 100 ml. Net fluid removal, intensive to 100 ml. Your non-CRRT intake is 200 ml in the form of feed and 100 ml in the form of injection, that is 300 ml. So total is 300 plus 100, that is 400 ml. And your non-CRRT output is 50 in the drain and 120 in the urine, that is 170 ml. So in order to remove this 100 ml from the patient, what you have to set up in the machine? 100 plus 300 minus 170, that is 230 ml. If you set 100 there, basically you add on fluid to the patient rather than taking fluid out from the patient. This is the crux of the calculation. So in order, you have to meticulously calculate how much fluid you are giving to the patient and how much is coming out from the patient, and use this formula to set up that amount in the machine to exactly take out the fluid that you want. So see, you have to feed in the machine 230 ml in that hour, so that you can take out 100 ml. So this you have to calculate every hour and you have to put it in that formulation. So this you have to remember. So what is the dose that basically you want to give? So we have seen that what should be the dose, that is what should be the effluent rate best for the patient. 40 ml, 45 ml per kg per hour. How much? So this started in 2000 by Claudio Ronco, and he found that 45 ml per kg per hour is equivalent to 35 ml per kg per hour, and it is better than 20 ml per kg per hour. So in that period, 20 years from now, from before now, we have found that maybe Ronco found that maybe a higher dose of around 45 or 35 is better than 20. So this was basically going on till 2006. Papers like this from Sudan et al. It came out. They found yes, 42 ml is more than 25 ml per kg per hour, and the mortality is better if you are using this dose. But the scenario changed in 2008 and 2009. Two simultaneous trials came in the Journal of Medicine. One by the acute that is the ATN trial. This came out from your USA, and the next one is the renal trial. It came out from Australia, and in both of them, they found that the higher intensity group, that is with a higher dose of 35 ml, they used here 35 ml versus 20 ml. Here they used 45 ml, 40 ml versus 25 ml. There was no difference in mortality. Though the higher dose in the renal trial just missed statistical significance in mortality benefit in severely septic patients. But still, as there was more mortality benefit, statistically it was found that it is not so significant. So ultimately, we are following maybe a lower dose of around a best practice region, maybe something between 20 to 40. So the reason being below 20, there is inadequate removal. Above 40, there is no benefit from higher dose. Maybe you are removing a lot of antibiotics, a lot of unintended solutes that you don't want to remove from the patient, that you are removing. That is basically blunting the good effects of the CRRT. So we practice between 20 to 40, but if you ask us, many of us intensivists personally, they might be preferring a bit higher dose in initial stages after the blood pressure stables. Then they come back to a lower dose, 20 to 40. So this has been challenged off and on. This is one of the Belemo papers that came out in 2013. We found that a higher intensity CRRT of 40 ml per kg per hour were associated with greater improvements in mean arterial pressure and vasopressor. And vasopressor requirements are decreased with higher intensity one rather than the lower intensity group. But failure studies should also be shown, like the ivory one, where the very high intensity hemofiltration was used at 70 ml per kg per hour versus 35 ml per kg per hour. No benefit was there, mortality benefit was there. So, as I have already told, that we don't reach our values, we have to prescribe high to get our what we want to achieve. This was shown by Venkatraman, 2002. He prescribed 24 ml, 24.5 ml per kg per hour. He achieved 16.6 per ml per kg per hour because he found that maybe not 24 hours, it was only 16 hours they could continue the CRRT with numerous stoppage times. Doremi study group basically confirmed this one. See, they started at around, if we start at around 25, we end at around 20. If we start around 35, I end around 26. Due to numerous stoppage times. So we have to prescribe more to achieve less. So what is the dose that ultimately we see that we recommend if at all you are doing intermittent hemodialysis, 3.9 per week, effluent volume of 20 to 25 ml per kg per hour for CRRT in AKI is recommended. And this usually requires a higher prescription of effluent volume. We are adding to this. Don't remember, when you're using a pre-filtered dose, your effluent volume, your effective dose comes down further, as I have already shown you. So how do you prescribe your CRRT? You take the name, age, sex, weight. Indication of CRRT should be given. AKI, whether what is the staging of the AKI or there, whether do you have any other reasons for starting CRRT. What is the type of therapy you want to give, the filter that you are using, the blood flow that you have given, what is the pre-dilution fluid, how much you are giving, post-dilution replacement, how you are giving, dialysate, how you are giving, patient fluid removal that you have to put to achieve something different that I will explain, what anticoagulation you are using, what effluent rate you have achieved, what is your effective dose that you are achieving, and whether it's a zero balanced or a negative balanced one. And you want to add certain other additives, like, as you know, that CRRT might cause a lot of hypokalemia, hypophosphatemia to the patients. You have to add sometimes potassium to the fluid. So whether you're adding something to the fluid or not, you have to write the prescription like this. And thank you so much for the patient hearing. And if you have any questions, the panelists are there. They are ready to answer. Thank you. I think there are no questions, Dr. Vivek. Can you find any question out there?
I
No,
don't
sir, there's no
actually.
question.
Oh,
No question.
Lopa is there? Yes, you are not there that time. So
yeah, actually,